Hello everyone, welcome to this evening's sessions on urology stones. I'll just give it like a minute or two for everyone to join, then we'll get started. Okay, we'll just give it one more minute, then we'll start. Okay, I think we can get started. So welcome everyone, my name is Hassan and I'm an F1 in Southampton, and I'll be teaching us tonight all about urology stones. So our learning objectives tonight is kind of understand how common are stones, what are some of the different types, what are the symptoms they can cause, are there any emergencies we should worry about when it comes to stones, how we diagnose these, and also the management. So stones is quite extensive, but I've tried to make it like as relevant as I can for the UKMLA and for your exams. So just to get everyone warmed up, if we could just put in the chat, or if you'd like to shout out, how many different types of kidney stones can you name? Okay, struvite, that's correct. Calcium oxalate, yep, that's correct as well. Well done. So, the main different types of stones we have, as you've mentioned, calcium, oxalate, and phosphate. Urate, uric acid, yep, true as well. Good job, guys. So we have the two calciums, oxalate and phosphate. We have uric acid stones, struvite, and cysteine. And later on, we'll cover these in a bit more detail. But these are the main type of stones patients can present with. And another question, just to get us warmed up, how common do we think kidney stones are? Like, what percentage of the population do you think has stones? You just have it a guess in the chat. %? That's a good estimate, yeah. Thereabouts. We're thinking of like lifetime prevalence, we're thinking around 11% in men and 9% in women, and roughly 8 cases per 1,000 adults. And in Western countries, like the one we live in, we're seeing increasing incidence. So they are quite common. When I was in urology, if we had like 30 patients on the ward round, a good 11 or 12 were coming in with stones. There was lots of outpatient appointments and elective cases. So they are very, very common. I think I was going to start off with a little bit of anatomy just so we can understand some of the complications that come with stones. So if we start at the kidney, as we all know, it's one of the organs that filters our blood to remove urea and other toxins to form urine. This urine is made up of water, urea, and inorganic salts, and we just need to park that in the back of our mind, the inorganic salts. This is a diagram on the left-hand side where you can see the renal pelvis, and that's where mainly the stones will start to form, as we can see the ureter drain down to the bladder. Ureters themselves are 3 to 4 millimeters in diameter, and they just transport urine from the kidney to the bladder. The most important thing to remember, which I think comes up quite often in clinical practice and exams, is there are 3 levels at which the ureter constricts. So normally you have the lumen of 3 to 4 millimeters, but at times it can constrict, and that's where often you get stones stuck. And this would be the pelvico-uteric junction, the pelvic brim, where it kind of covers over the common iliac artery, and the uretrovesical junction, where it plugs into the bladder. So these 3 areas are important because they're often places where stones can get stuck, and then we can get the complications. Now, what causes the stones to form is, like I mentioned, when we make urine, we have some inorganic salts in the urine, and sometimes these solutes can crystallize and you get stones. The term nephrolithiasis is just to describe the formation of stones in the kidney, and it summarizes all the different types of stones and their locations. Ureterolithiasis is when they exit the kidney and they travel downstream to the ureter. So it's basically our kidneys filter our blood, they remove the urea, water, and also lots of inorganic salts, and sometimes when they crystallize, they form stones. The way this happens is when you can get plaques of calcium deposited on the renal papilla. And these are called Randall plaques, as you can kind of see in that diagram there. And these serve as the building blocks for stones in many cases. So once you have these Randall plaques, that's where all the different inorganic salts, compounds can start forming around, and that's when you get stones. And as for, why you get them in some people and not others, there's different things that can kind of precipitate it. So one thing in the body is whenever you have static urine that's not flowing well, you just have increased the likelihood of solutes crystallizing. And this can happen due to anatomical features, like urethral stricture. Or also you commonly see in patients who have retention and they struggle to fully empty their bladder, you can get bladder stones for the same reason. Another thing is infection. So it's this double-barrel effect where a stone can increase the likelihood of infection, but at the same time an infection can precipitate a stone, and quite commonly you get struvite stones. Another thing is low urine volume. So a lot of times you'll see patients come in and they're typically people who are quite dehydrated most of the time, and they have very poor oral intake, and they're the ones you see increasing incidence of stones in. At the same time, diet can matter. If you have very high sodium and oxalate input, you can get increased risk of stones. And also genetics. If you talk to a patient and they have a family history of stones, such as in their parents or grandparents, it increases their likelihood of forming stones themselves. Another thing is drugs. So certain drugs increase the likelihood of stones forming, and we can split these into 2 broad categories. One category is where they cause metabolic abnormalities or changes in the metabolic makeup of urine, which increases the chance of forming stones. And these are loop diuretics like furosemide, carbonic anhydrase inhibitors like acetylazimide, and also people who take a lot of laxatives. The other class of drugs are the drugs where they kind of form the main component of the stone. And this you have your antibiotics like ciprofloxacin, antivirals like indinavir, sulfonamides, and also magnesium trisilicate. So you have to also watch out for when a patient comes in, just to have a quick look at their drugs to see if there's anything that can be causing the stones. I thought I'd quickly mention cystinuria, as you mentioned earlier, cystine stones. So this is a genetic condition. It's autosomal recessive, and cysteine is an amino acid. And in these patients with cystinuria, they just have large amounts of cysteine in their urine, so that increases the likelihood of getting stones. So it is quite rare, but you can sometimes see it present. So we've talked about what causes stones in general. Calcium oxalate stones are one of the most common stones you'll see, and it has its own risk factors for it. And they are similar, like you get a positive family history, but you also get other conditions that increase likelihood, like diabetes, obesity, hypertension, increased urinary acidity, and increased oxalate absorption. So these are some risk factors in particular for calcium oxalate. And when we come to it later on management, a lot of management or prevention of stones, which we'll come across later in the presentation, is tackling some of these risk factors and reducing them. So we've covered, some of the anatomy of the kidney and the bladder, what can cause stones to form, the pathophysiology of them forming. Now we can take a slightly in-depth look at the different types of stones. For your exams and for the UKMLA, you don't have to know them in that much detail, but just a little bit about each type of stone, just so you can help differentiate in MCQs, would be useful. So if we start off with the most common, calcium oxalate stones. So these make up 70 to 75% of all urinary stones. So most likely if someone comes in with a stone to hospital, it's likely to be calcium oxalate. They form in acidic urine. There's two types, monohydrate and dihydrate. I put pictures of the dihydrate ones there. They're quite jagged. And the important thing about calcium oxalate is they're radio-opaque. So if you x-ray a patient, like you do an abdo x-ray, you're likely to see them on the abdo x-ray, which is quite important when it comes to some of the interventions later on. But most likely, you get a question, you're unsure, most common type of stone is calcium oxalate. Calcium phosphate are 10% of all urinary stones, and they're a bit different. They're off-gray/white in color. They grow faster, and they form in alkaline urine. However, they are still radio-opaque, so once again, they'll come up on an abdominal x-ray. And they can be associated with hyperparathyroidism and renal tubular acidosis. So in summary, they're quite a lot less common. They form in alkaline urine, but importantly, they're still radio-opaque. Uric acid, as you mentioned before, they only form in acidic urine, so that would be a pH less than 5.5. They're roughly 10% of all urinary stones, and roughly they're like yellow, orangish, or brown. Moving on to struvite stones, so these are most associated with infection and a raised pH, so alkaline urine. They form roughly 8% of stones. As you can see from the picture there, they look quite chalky and grey. But the most important thing is they're most likely to come in with infection. So that kind of covers the different types of stones. For exams, you don't necessarily have to know the ins and outs at all, but as long as you know that calcium oxalate are the most common, patients with cystinuria would most likely form cystin stones, and, struvite stones are quite common in infection. That should get you through most of your MCQs. But just a quick question. We now know a lot about stones, but what kind of symptoms can they cause? If you'd like to put in the chat, like if a patient's presenting to ED or the GP, what are they most likely to complain of with urinary stones? Yeah, very good. So we have pain. Someone else mentioning pain, which is very true. Hematuria, yep, you can get blood in the urine from the stones. Whereabouts will we get the pain? Like what specific part of the body would someone say that it hurts? Nausea and vomiting, that's true as well. Renal colic, that's very true. So similar to biliary colic, like kind of pain that kind of comes and goes. Where exactly do you think we'd get this kind of pain in our abdomen? That's excellent. That's really, really good. Loin to groin pain or flank pain, which is your typical presentation for kidney stones. So although they may be asymptomatic, like oftentimes a patient can come in with a different complaint, you scan them and they have a stone. A lot of people, when you get pain when it's obstructed or infective, is loin pain, so around your your right flank, your left flank. It's a colicky pain. It can cause nausea and vomiting. And most importantly is as the stone travels from the kidney down the ureters to the bladder, you get loin to groin pain. That's the main thing we're looking out for. So just summarize again, they can be asymptomatic, but when they're obstructed or infected or just generally causing inflammation, it's loin pain that's radiating to the groin, and it's quite colicky and cause nausea and vomiting. Hematuria comes about, as it passes along. It can go through constrictions and damage the urinary tract, so that's where you get the bleeding. So the question is, a lot of people will present with flank pain, and you might have someone who comes to ED and they say, I've had flank pain, but I'm also very shivery, I've had very high fevers. Do you think that's anything worrying? What could the fevers kind of indicate? Like, what would we be worried about? Infection, really, really good. That's the main thing. So an infected stone or an infected obstructed stone is a urological emergency. And basically what's happened is your stone has become obstructed, it's blocking the flow of urine, or it's developed an infection around there. And basically as long as the stone is there, the infection will continue to build up, and it can travel up back to the kidneys and cause pyelonephritis. It can spread to the blood and cause sepsis. And at the same time, it affects kidney function. You get a drop in your EGFR, you go into AKI. So this is a urological emergency that needs to be treated. And the normal way you treat it is you give IV antibiotics, and you need to decompress the kidneys. So you'll put in either a urethral stent, so that's where you go from below with through the urethra, through the bladder, up the ureter, and you put a stent, which is basically a very long rubber tube that's hollow, and it allows your urine and the infection to drain, and it saves your kidneys. Alternatively, you can get a nephrostomy, which is done by interventional radiology, which is a tube that drains the kidneys directly from the side. So they use an ultrasound, they put it into the renal pelvis, and it drains. And the big thing we're doing with this is we're trying to save the kidneys. So we're trying to get the flow of urine out so you don't get hydronephrosis, and we're trying to drain out the infection so you don't get sepsis. So that's the one thing you should remember. Anyone comes in with flank pain and fevers, you need to do some blood tests and most likely need to admit them. Some of the other reasons, excluding someone coming in with infection that you need to intervene is if someone has a solitary kidney. So you can have some people who they've had their kidney removed due to malignancy, or they've donated a kidney. If you have an obstruction stone in one kidney, it is an emergency. A significant enough drop in EGFR, so again, like an AKI 2 or 3, that's reason enough. Sometimes people come with uncontrolled pain, so you try all your analgesia and it still doesn't help at all. It's worth admitting them and trying some stronger antibiotics and potentially trying to do surgery. And also, like we mentioned, it can present with nausea and vomiting. If they're unable to keep anything down and they're getting dehydrated, it can cause an AKI, so you don't want to admit them for IV antiemetics and fluids. So these are some of the other reasons apart from infection. So we've talked about, how someone can present with stones, and let's say someone comes in to your GP clinic complaining of flank pain. What are the things we can do to diagnose it, starting from like simple bedside tests or types of imaging? Like what do you think you'd first do to kind of investigate further? Urine dipstick, that's really good. So yeah, someone comes in, you dip their urine, you can have hematuria, you can have raised nitrites, raised proteins, which could show a UTI or potentially point you directly to have a stone. Some of the other things, obviously apart from taking a history, the main thing in our history when someone comes in with flank pain or abdominal pain is you want to rule out other pathologies. So like in a young woman, you'd want to rule out like an ectopic pregnancy, or in women in general, you'd want to rule out ovarian torsion, or anything that's an acute abdomen that would need to go to a general surgeon. So once you'd rule those out from your history, your examination, it's just mainly renal angle tenderness, urine dip, as you mentioned. And the main thing we're doing is bloods. Bloods don't necessarily help you with your diagnosis, but it helps check that, number one, they're not infected, they don't have raised inflammatory markers, and there's no drop in EGFR or AKI. The main thing that helps with diagnosis is often imaging. So like we mentioned, stones that are radiopaque, like calcium oxalate, we can do abdo x-rays, and you can see in the red circle there's a very little stone visible. So that's like a first-line thing you can do. Staghorn calculus are also visible. You just have to watch out for uric acid stones which aren't visible in x-ray. So if someone comes in, we can do an abdo x-ray. We can also do an ultrasound. Ultrasound is useful for visualizing kidney stones. Ureteric stones are a lot harder to see. But something that can help is you can see the secondary signs of having a ureteric stone. So you can see hydronephrosis. You can see a very angry and inflamed kidney. But the gold standard for imaging is CT-KUB. If you ever do urology as a job, all you ever call radiology to do is vet CT-KUBs for everyone. And the reason why is it's a scan that's dedicated to pick up stones. So it's non-contrast, and it's really, really useful. So you can see in the two pictures up there that ureteric stones, they show up very bright. And as well as looking for the stone, you can look for hydrouteronephrosis, so you can see that the ureters are very wide, or you can look for kind of inflamed kidneys. You can see in some scans perinephric stranding. But our main thing that you should know is if someone's come in to ED or A&E and you're suspicious of a stone, you should get a CT-KUB. So we figure out, how someone presents with stones, how we diagnose them. We move on to management. And there's different ways we cover management. Firstly, most people are coming in complaining of the stones, so we'll tackle analgesia first. So the main thing that works for ureteric stones and kidney stones is diclofenac, that's PR. So PR is perirectal, so a suppository up their backside. And some patients will be a bit, skeptical of trying this, but if you explain to them that it generally works the best for them, and also you get like reduced side effects of other NSAIDs like peptic ulcers. So PR diclofenac is a thing you should try. Oral NSAIDs, if they're kind of a bit skeptical of the PR diclofenac, but you always remember to prescribe a PPI such as a omeprazole to protect their tummy, because you don't want peptic ulcers. If it still doesn't work, you can use oral morphine or IV morphine, but typically NSAIDs work best for this kind of renal colic. Moving on to conservative management. So not everyone who presents with a stone necessarily needs surgery. If a stone is less than 6 millimeters, it's quite likely to just pass itself. And a good way of doing this is if you just Google a mimic calculator, which we've sometimes done on the ward round, you can put in the person's age, the location of the stone, the size of it, and I think you also put in the creatinine or EGFR, and it gives you the likelihood of a stone passing. And typically, if it's like greater than 90% chance, there's no need to intervene. Something that we can do to help a stone pass itself is to give tamsulosin. Now, you've probably heard of tamsulosin for benign prostatic hyperplasia for men with chronic retention, but you can also use it to help expel stones. It's an alpha adrenergic receptor antagonist, so it kind of relaxes the smooth muscle, kind of widening the lumen so the stone can pass out more easily. So yeah, main thing for conservative is less than 6 millimeters. It's likely we don't have to do anything, assuming that their kidney function is still good and there are no signs of infection. Something we can do is preventative management. So this, with all people who present, you encourage adequate hydration, like 2.5 liters a day. The more specifics about alkalizing the urine is only really applicable once you've kind of identified what kind of stones they've passed. So anyone with a suspicion of kidney stones, you try and send their urine for analysis or the actual stone for analysis, so you can figure out what the stone is, and then the management. But for certain things like uric acid stones, you have to give them potassium citrate to raise the pH of their urine, as that reduces the chance of other ones falling. For people with high calcium in their urine, you can give them thiazide diuretics, and also things in the diet. So high incidence of calcium oxalate stones, you recommend them a low oxalate diet. So the main thing with this is just adequate hydration, dietary changes, and sometimes medication once you know what stone they have. In certain cases, you have to have some surgical intervention to break up the stone or just outright remove it. And one of the first things is something called extracorporeal shockwave lithotripsy, or I think an acronym for it is ESWL. And this is a non-invasive procedure, so the person's awake, and it's basically you just use a probe which shoots shock waves at the stone to break it up. So you basically lie the person down and you target the stone with the probe, and it breaks up into smaller pieces, so it increases the likelihood of it passing. The one caveat for this is it has to be visible on X-ray, because when you're doing the procedure, you use X-rays to target the stone. So with all patients, you do an abdominal X-ray, and if you can't see a stone, this isn't suitable for them. People can have multiple rounds of shockwave lithotripsy, and the one thing is it can cause hematuria and pain, as the fragments still need to pass through the ureter, so you can still get some symptoms for a while. But that's one of the first things you can do. The second thing is much more invasive. So ureteroscopy with and without laser lithotripsy. So this is done under general anesthetic, and the way you do it is you pass a probe with a camera through the urethra, through the bladder, through the urethra, through the bladder, up the ureter, and there you can visualize a stone. And if it's small enough, you can pull out in a basket, or you can use the laser to kind of break it into smaller pieces and then pull out the pieces, or just turn them all into dust so they can flow through. And with this, sometimes you just break them up, pull them out, and leave it. Sometimes you leave in a stent, because you can have a lot of, if you have a lot of fragments and a lot of dust, the dust itself can obstruct the kidney. So you can leave in a stent for a while and later bring them back to remove it. So it is an invasive procedure. It's done under general anesthetic, but it has quite a high rate of the patients being stone-free after the operation compared to shockwave lithotripsy. So that's one of the things you can do as well. Patients with bigger stones that, it's not really appropriate for a previous method, you can do something called a percutaneous nephrolithotomy. So percutaneous, it's through the skin. So instead of going up through the urethra, we're going literally in the flank. So you put a probe straight into the kidney, and here you can pull out the stones or break them out into smaller pieces. And you mainly use this for very, very big stones in the kidney. And this is a much more invasive procedure. As you put in your probe, you can damage the kidney itself, you can damage surrounding structures. So it's more high risk, but typically it's for patients with bigger stones that are still symptomatic. And that's pretty much the end of our session. If I just give you a quick summary, the main things to know: if someone has a stone and they have flank pain and they have signs of fever, it's highly likely they have an infected, obstructed stone. That's a medical emergency. You need to admit them to hospital, and you need to decompress the kidney with surgery. Stones are very common, but they may be asymptomatic and just incidental findings. And your management can be conservative depending on if the stone is small enough. And you can always use the MIMIC calculator. So yeah, that's the end of the session. I'd really appreciate your feedback, and I'd be happy to answer any questions if you have them. I'll also put the feedback link just in the chat. You're welcome. Yeah, I'll also share a link for my next session on prostate cancer, and also tomorrow I think they're doing quite a good session on breast surgery as part of general surgery, so I'll share that as well. Okay, guys, thanks for coming. You're very welcome. I'll just hang on a bit just in case there's any more questions. Oh, you're welcome, guys. Thanks for coming. Okay, if there's no more questions, I'll say good night to all of you. Good luck with your exams, and have a good evening.